Okay, so hello and welcome everybody to today's Q Primary Care event. My name is Ramya Matthew. I'm a GP and I'm also the convener for this group. Today, the topic is going to be about sustainability in primary care. And in particular, we're going to be focusing on how we can achieve low carbon, high quality asthma care. And the idea of today is to bring together people who have knowledge, expertise, and enthusiasm for this field. And we want to lay the foundations today for hopefully what is going to be a bigger piece of work that will happen over the next 3 to 4 months. So this is really the first step in that process. And it's a chance for us to discuss potential ideas, where we can work and where we can influence. And I'm not going to be chairing today. It's going to be Dr. Arti Bansal. I'm sure lots of you here know her already. Arti's a GP. She's also a clinical academic. But most importantly, she's also the founder or co-founder of the Greener General Practice movement. And she brings a lot of enthusiasm and passion to this area. So I'm going to hand over to Arti now, who's going to do a short introduction around planetary health, and in particular, the importance of high quality, low carbon asthma care within the wider context of sustainability in primary care. While Arti does her introductions though, could I ask that people just post a short introduction within the chat, just to let us know who you are and what your background is. Because what's going to happen afterwards is we're going to put people within breakout rooms. And I'm quite keen to get a mix of people within the breakout rooms. So it'd be helpful just to know, who you are and what your background is. So be grateful for that. For now, I'm going to pass over to Arti. Thank you, Arti.
Thanks, Ramya. And thanks everyone for coming. So as Ramya said, today's really an opportunity for everyone to get their collective brains together and for us to really sort of consider what can we do to try and create user-friendly QI resources to push forward the high quality, low carbon asthma care agenda. And what I'm going to do, I just tell you what the plan is for this workshop. So hopefully I'm not going to go over 20 minutes to just give you a brief outline of the sort of the lay of the land, as it were. Most of you know this better than me, and I'm really, really pleased that we've got some great experts in the room. Most of the research that I'm going to be talking about is actually written by people like Alex Wilkinson and James Smith, who are in the group today. So I'll just give you a brief introduction, and then most of the hour and a half that we have is going to be for people to get together in breakout rooms and actually to then think about 5 questions that we're going to pose. I'll tell you what those questions are in a minute. And then we're going to get back together, we're going to do feedback from groups, and we're going to have a short amount of time to talk about next steps. So I'm not going to talk about planetary health generally, because I think most people do understand that, and we want to spend most of our time in the workshop today thinking specifically about low carbon, high quality asthma care. But for those of you who aren't so familiar, the reason to go low carbon in all of our care is because climate change is the biggest global health threat of the 21st century, but tackling it is also our greatest health opportunity. And that's because so much of what we will do to tackle the climate and ecological crisis actually improves health now. So not only are we protecting future health by preventing the impacts of the crisis, but we're actually doing the things that we would want to do now anyway. And we have the potential to do this in a way that reduces health inequalities. So it's really about the idea that we need a healthy planet to have healthy people. But in terms of low carbon respiratory care, I wanted to put up the 4 principles of sustainable clinical practice, which were conceived by Dr. Frances Mortimer, who works at the Centre for Sustainable Healthcare. And she has these, I really love these 4 principles as a sort of a framework of thinking about how to do sustainable clinical practice. And those are prevention, patient empowerment, lean systems, and low carbon alternatives. So from a respiratory point of view, prevention might be thinking about what can we do to reduce air pollution. Patient empowerment might be how can we improve people's self-management. Lean systems could be thinking about efficient clinical pathways, which are actually meeting the needs of patients where they are, reducing any duplication in the system. And then low carbon alternatives are looking at inhalers. And many of you will already know this, but the reason there's a focus on inhalers is that there's a real relative difference in the carbon footprint of different inhalers. So the infographic is taken from a website called greeninhaler.org, which is started by Alex Wilkinson, who's here with us today. And it just shows you visually the really huge difference between the carbon footprint of a metered dose inhaler, which is the puffer inhaler that most of us are familiar with, and a low carbon inhaler like a dry powder inhaler. And those are the figures as well alongside. And the reason for that is because metered dose inhalers contain propellants, and these propellants have something between 1,000 to 3,000 times the global warming potential of carbon dioxide. And that's why MDIs account for such a disproportionate amount of our NHS carbon footprint, 3 to 4% of the entire NHS carbon footprint, and approximately a quarter of the GP prescribing carbon footprint. And there's variation in how much MDIs are used in Europe. So this is from a paper by Lavorini in 2011, which shows that you can see the UK is at one end of the scale. You know, we pretty much are using MDIs for the majority of our inhalers, whereas somewhere in Sweden, it's very much the minority. And also, this is a very recent paper that was published in Thorax, which found that in the UK, 70% of all inhalers prescribed are short-acting beta agonist inhalers. So that's basically your blue salbutamol inhalers. And there's potential overuse of these short-acting beta agonist inhalers in up to 50% of patients. And for those patients, on average, they will have 6.5 prescriptions a year. And that leads the UK to have almost treble the emissions from just salbutamol than most European countries. This is what I found from the Open Prescribing database, which gives you up-to-date information on the number of MDIs prescribed as a proportion of all inhalers, but excluding salbutamol. So this is probably likely to be preventer inhalers, and it used to be 51%. It's actually going up. It's now about 57%, but you can see there's a lot of regional variation. So it could be nearly up to sort of between 60 and 70%, or sort of much lower than that. And then just to sort of highlight the issue of disposal as well, is that at the moment the vast majority of MDI inhalers are going to landfill, and when they go to landfill, people just put them in the bins. The propellants will get released into the atmosphere. There have been attempts to try and get some recycling schemes going, and there was a GSK recycling scheme that people might have been aware of. That seems to have folded. There's a Teva recycling scheme that's a bit patchy. So that's the best thing you can do for your inhalers is once you finish them, is get them recycled. But the next best thing is to get them incinerated, because then that gets rid of the propellant gas, and it's much safer. So it's another thing that we need to sort of work on. So I've tried to kind of just write down where I think the intersection is between low carbon asthma care and high quality asthma care, because I think there's a real opportunity here as we're trying to decarbonize asthma care, that we can also improve care at the same time. And I think it's well understood that asthma care does actually need improvement in the UK. We're not giving people, you know, the basic sort of care that Asthma UK suggests that everyone needs to have, and outcomes are not as good as they could be. There was a recent paper as well that suggested that patients kind of need at least 2 hours of self-management support for their asthma before you see improvements in health and quality of life outcomes for people, and in reduced healthcare utilisation. We've already seen that statistic that there's quite a lot of SABA overuse in the UK, and observational studies would say that if you're using more than 3 salbutamol inhalers or SABA inhalers a year, then that's associated with poorer outcomes. So more likely to need to see the doctors, more likely to be admitted to hospital, more likely to have exacerbations. Alex, and do correct me if I'm wrong here, but my understanding is that if your control is good, then you're unlikely to need very many inhalers a year. You're probably looking at 1 or 2 blue inhalers a year. And also, really, that's step one of just SABA is there's hardly anyone who's going to need, who's got a diagnosis of asthma who should be on just a blue inhaler. It's very few cases where people just need to be on a blue inhaler. The other side of the equation is that generally it's thought that metered dose inhalers are more effective with spacers, but real world use of spacers is low. So I think it's something like 25% of patients who use spacers on a day-to-day basis with their metered dose inhalers. The other problem with metered dose inhalers is they don't have dose counters. And because you're not using them, particularly the salbutamol, you're not using regularly, patients are at risk of either ending up using an empty inhaler, so they're just inhaling propellant, or more commonly, thinking that they run out of the inhaler and disposing a half-used inhaler. And I think there was some study to show that when inhalers were brought to recycling centres, a lot of the time, half of the medicine was still in there. Dry powdered inhalers, on the other hand, don't need spacers. They're a different technique. So with the metered dose inhalers, it's a sort of a longer and slow breath, whereas a dry powdered inhaler is quite a fast, quick inhalation. But there are some people who can't use dry powdered inhalers, but they can be used safely and effectively by the majority of patients. And often they'll have dose counters as well. So that's reducing the risk of using empty inhalers, that's reducing the risk of waste, but it's also an aid to compliance and aid to adherence as well. So what's the policy context in the UK? Well, reducing greenhouse gas emissions is actually part of the UK government's 6th carbon budget. Back in 2019, the NHS England long-term plan proposed a 50% reduction of the carbon footprint from inhalers within 10 years. Many of you will know that there is a greener NHS that was launched in October 2020, and we have a net zero NHS programme. And one of the first things that programme is going to be focusing on is reducing metered dose inhalers' carbon footprint. It's one of the 2 clinical priority areas. The other one is anaesthetic gases. The GP contract, the new GP contract, has something called the Impact and Innovation Fund. And there's a target there to shift not the salbutamol, not the reliever inhalers, but the preventer inhalers from what was 51% to 45%. It's actually now 57%, as I showed you in those figures before. And there's been guidance coming out. So there's a nice patient decision aid, which is supposed to help people think about whether or not they might want to change their inhalers to dry powdered inhalers. It's referenced in the BTS guidance, and the NHS England Inhaler Group is considering some national guidance. And I should mention also that the Primary Care Respiratory Society has also got some new guidance around this. So there's a lot going on in the policy context. That's just an image of the patient decision aid from NICE. So in terms of sort of developing user-friendly QI, there are multiple areas where I think this might be useful. So back in a couple of months ago, I can't remember now exactly, Georgie and I did a webinar on net zero general practice, which included Martin Marshall, and we were talking about the kind of incentives that people need to start on a net zero pathway. And one of the things that Martin Marshall was interested in was, what about quality improvement in the QOF? You know, how can the quality improvement section of QOF be used to incentivize general practice to work towards this? And so there may be an opportunity there. As I've already mentioned, all the ICSs will have this memorandum of understanding, which states that one of their clinical priorities is to reduce the carbon footprint from metered dose inhalers. potentially, maybe we could talk about locally enhanced LESs, you know, to support practices, or maybe prescribing incentive schemes. We have a website at Greener Practice where we can post these quality improvement resources, and also the Green Impact for Health audit has sections around inhalers, and so whatever resource that comes out of this can be linked into that. So the practices who are already on, you know, logged in with the Green Impact for Health audit can make use of the resources there. So some of us have been sitting and thinking about what are all the reasons why there's high MDI use in the UK. It seems to be so much higher here than it is in other parts of Europe. So what are the reasons, and why where might we need to sort of put our actions? Now, I sent a sort of a document through, which I'm not sure how many of you have actually managed to read, but there's a little bit more detail on that, where I've mapped the causes, but also started to put down some of the solutions as well. And I've got to thank Tamsin and Georgie here for helping me to do this visual. In fact, they did the imaging of that thinking, so thank you very much. But I'll just briefly go through the thinking that a group of us have got together and done so far, so that we're not starting from scratch when you get into your breakout rooms. But this is by no means the full answer, and if there's huge glaring gaps, then please do talk about them in your breakout rooms. So at the bottom there, you've got the climate and ecological crisis and air pollution, which are driving these problems, and at the top we've got the 4 principles of sustainable clinical practice. And I think what we've done is we've divided it into 3 areas. So you've got the SABA overuse, the inhaler disposal, and then the switching people in prevention from MDIs to DPIs. So what are the barriers of switching there? And in the SABA overuse, one of the things I think I've found is not easy is, how do we identify where the overuse is? So as you know, when those prescription requests come into us, how easy is it for us to easily sort of say, how many inhalers has this person had in the last 12 months, so that we can actually decide whether or not we're going to prescribe anything more, or whether we're going to ask this person to come for a review. From what I have to do at the moment is go into the person's notes, go into the salbutamol prescription, right click, and then look at prescription history. So that's quite a lot of buttons, and I'm wondering if there's an easy way for us to think about, and how can that information be extracted a little bit easier, because it may be that the only way that these people are being identified is if an audit's being done. There's also the lack of knowledge. So this is lack of knowledge from a practitioner point of view and a patient point of view on all sorts of things. That what is good control in asthma? You know, how much use is overuse, and you know, that kind of lack of knowledge might be driving SABA overuse. What might be the solutions there? Should we be empowering patients rather than clinicians, or should it be at pharmacy level? Anyway, those are some of those ideas. It can actually mean poor control, you know, and we need to be identifying those people where there is poor control. It could be too much dispensing, but it could also be poor control. Somebody mentioned last time we talked about this, that could it be that patients are concerned about the cost of 2 inhalers, and so they'd rather just manage their asthma using the inhaler that gives them the relief when they actually have the symptoms, rather than the preventer where they can't really measure the impact of that unless they're using it over time. Anxiety, using small to treat anxiety rather than using it to actually treat asthma symptoms. There's poor technique, which I think there's lots of studies now to show that the vast majority of patients don't have good technique. It does help when they're taught it, that does improve things, and it can help when they have a spacer device, but technique is a big issue. Are we just dispensing them too frequently? What are the barriers at pharmacy level that mean that maybe there's over dispensation going on? And then this was an issue, the diagnosis issue is one that came up in my practice, where we found that patients where the clinician was querying, is this asthma, were being given a blue inhaler rather than a preventer inhaler, and then being sent away. And because they didn't often come back for their review, they ended up on blue inhalers without ever having a diagnosis. So that there was 2 issues there, but you know that there may be an issue around just getting people to know about the new guidance around how we manage diagnosis. With the inhaler disposal, you know, we've talked about when is the inhaler empty, and also just how convenient and is it to do safe disposal back to your pharmacy. Do they even know that that's what you're supposed to do, and how can we make that easy? In terms of the barriers to switching, so that we're MDIs are being switched to DPIs, which is part of the incentive in the contract. Again, there's a knowledge issue around, you know, there may just not be a knowledge about the potential advantages for some people of DPIs if they're not willing to use the space, so the potential advantage of dose counters, and then of course the carbon advantage. I found when I'm talking to GPs a lot that they'll just say, I just have 2 names in my head, and that's Clenil and Ventolin, and that's what I prescribe. I don't have the time to look up all the different kinds of inhalers. So the familiarity and also the concerns about, I don't know how to use all these different inhalers, I couldn't possibly advise patients, there's too many different types, can't keep up. There may be some concerns about managing exacerbations. People seem to have got the idea that, you know, one of the advantages of using MDIs and having spacer devices is that you can then use them. If somebody has an exacerbation, you give that advice about taking up to 10 puffs through a spacer device, and then what you do if that doesn't work. So I think some people can be quite concerned about switching to an inhaler that doesn't have a spacer device, and what do you then do in an emergency? There's a potential problem around children who it's generally accepted should be on MDIs, although there's variation here. So in some parts of Europe, they switch children as young as 6 onto DPIs, whereas a lot of people will say we shouldn't be thinking about that until they're at least 12. But even if at 12, well, how do we do that switching? What's our system to do the switching? Should we be thinking about things like an education program, like a Desmond education program that's based at schools, and maybe from the junior to senior school transition, perhaps because at senior school, children are less likely to use spacers. That's an idea that Honey Smith has suggested. And then also, what about QOF criteria? At the moment, when we do our asthma reviews, we're asking people, we ask people things like, how many puffs have you been using of your salbutamol inhaler in the last week on average? And I wonder if that's really accurate for us getting an idea of control. Should we have a QOF criteria around having discussed low carbon alternatives with them? Should we have a QOF criteria going back to the Sabra overuse around how many inhalers they've used in the last year? Would that help? And where do these interventions need to happen? Do they happen at medication reviews, asthma reviews, which are largely done by nurses? Do we need to change the asthma inhaler guidances, the PAP maybe? And do we need to look at QOF, both in terms of QI and criteria? So that's the kind of mapping that I've been doing with some other people, just to give you a sense of what all the possibilities might be. And this is now, I'm going to stop talking very soon. This is now where we're going to ask you to go into breakout rooms and to do some thinking. And these are just some of the questions that we thought would be good for us to think about. So Ramia's very kindly put some Jamboards together. And so each there's one Jamboard for each of these questions. And when you go into the breakout rooms, you'll be able to use the sticky notes on the Jamboards to answer each of these in turn. And the questions are, what do we consider to be high impact and amenable to quality improvement? What interventions are likely to be sustainable? So what we mean by that are likely to be able to carry on and not need a lot of time and resource investment going forwards. What do we want our resource to be? What's most likely to be useful? Who do we need to partner with to ensure that there's a mandate around this and the right levers are in place? And what skills do we need to produce the required resources? Do we have them within the group, or do we need other skills as well? So I'm going to stop there and hand back to Ramya and Hugh to get you all into breakout rooms.
Thanks, Artie. Yes, so just to clarify, so the next session we're going to go split off into 4 different breakout rooms. We'll have about half an hour, and then we're going to use that time to go through each of these questions. Within the Jamboard, there are 5 slides, so and each question has got its own slide. So what you need to do is once you've finished with question 1, which you might spend 5 minutes on, for example, you then move on to question 2, which is on the next slide. If anybody is struggling with Jamboard, then just let me know and I can come in and give you a hand. But what will happen shortly is that Hugh is going to share the links for each group's Jamboard, and then you should be able to go into it and edit it. There is a toolbar on the left-hand side of the screen, and the 4th one down provides you with a sticky note option, and you essentially press on it, type what you want, and that's your sticky note done. And the idea is that we just capture all the thinking from the different groups, and then after that we'll have half an hour for us to feedback and have a bit of a group discussion and see what we've got. Does that all sound okay? Hugh, are we good to put everyone in breakout rooms? And will it be clear which Jamboard is for which group, just so that people have got the right one? Yeah, okay, perfect. Thank you.
Right. So we had 4 breakout rooms. I don't know if people remember what number of breakout room they were, and whether we should have said this before, I always forget to say this, nominated someone to sort of feedback from the group. But is there somebody from breakout room 1 who wants to feedback on the thinking that you did in your group?
Yeah, so we were breakout room 1. So do you just want a couple of sentences to summarize what we talked about?
You've got longer than that.
Okay, fine. All right. So we talked a bit about initially about top-down changes. So do we need to think about targets at a government level, and making these things kind of making a change that's looking ahead to kind of 2030 and beyond. We talked about embedding it into like your model design about going into QoF, and whether that might make it more sustainable in the future, that we would keep reviewing it rather than having a local plan that then the next year something else is on the agenda. We talked about maybe pressure on the pharmaceutical companies to think about the propellants and whether there's changes needed there. We had quite an interesting discussion about circular economies and about whether looking at the life cycle of the overall system and things like that would help us review where to target. We talked about the kind of what I think everyone in this movement believes, which is that this is about good quality care, and that actually if we improve overall asthma control, I think everyone's in agreement that's what everybody wants, and it improves morbidity and mortality, and that actually if we get our SABA overuse down, and we talked about how in terms of making GPs' kind of practice nurses and GPs' lives easier to do things that make that simple. So whether that be having good off-the-shelf ideas, case studies, whether that being script switches and utilising IT to say, pop up in the similar way we have other pop-ups to say, did you know there's an alternative inhaler? Similarly with looking at formularies and CCG guidance to again make it really simple for people so that when they see things that you can pick it easily, and you're not having those kind of discussions as well as having to think about what to do. And we also talked about embedding it into all the streams of work that we do, so that in ICS groups that we would have involvement in everything that's happening at an ICS level, including this. I think that's the majority of what we talked about. I don't know if anybody else in the group has anything to chip in. One final point which is something that I think we just hadn't really got to, about how you actually make the incentives happen and what the incentives should be. So I was saying about in our ICS, we're having a bit of disagreement about whether the incentives should be around education plus percentage reduction, or, you know, somewhere else is saying, you know, about having conversations with patients. It's about what you're actually incentivizing on paper, rather than everyone in agreement about the overall themes, what the actual medicines optimization schemes are saying and what we're doing.
Yeah. Okay. All right.
I'll pop a link to the Jamboard that we did, because we did it all on one page, so people can have a look as well.
Yeah, actually, so the Jamboard didn't work on our in our breakout room, which I think our group was group 2, so I'll feed back in a second. But I was actually thinking that it probably gave us a little bit more time to talk, because we weren't all having to write our thoughts on the Jamboard as well. But thanks, I'm glad that it's captured on the Jamboard. And you sound like you had a really broad and wide discussion in your group about all the different areas that you might sort of focus on. So in our group, we decided that there were 2 targets, 2 areas of focus that people talked about. So just like your group, we talked about targeting SABA over reliance, and we also talked about those people who were on different inhalers. So if they're on one on a DPI and an MDI, then sort of putting it together so that they're not on a mixed economy of inhalers, as it were, and that might be a first start. Then we talked about where do we do this, and we were lucky in our group to have 2 pharmacists, and they talked about how actually one of the key things, that one of the part of the essential services for pharmacies is to check that people know how to take their medication. And so we could be asking our community pharmacists to be doing this service for us, so that might make it more sustainable, is actually if they're looking at the inhaler techniques and they're potentially even asking the patient to come back in a couple of weeks and rechecking it, you know, making sure that they're happy with that. That could be a way of making it more sustainable and actually effective. There's also a new medication service that's been commissioned for pharmacies, but so that if anyone is being started on a new medication, then that should be part of what the pharmacy is doing. In terms of how do we make it, so sort of carrying on in terms of how we make it sustainable, we talked about, similar to you, we talked about IT solutions, so things that are easy, make it easy for people to do the right thing. Do we need to look at an easy way of changing the default settings, so that salbutamol is only prescribed every 180 days and it flags up? How, as I mentioned before, is there a way of gathering the IT data so that we can identify at medication reviews whether somebody's overusing SABA as well? And then we talked about education, and it was felt in our group that you really need buy-in from patients and buy-in from practitioners to move this forwards. And some of that buy-in is actually sort of carbon literacy training, so it's the bigger picture buy-in around why actually the climate crisis is an important thing for us to be acting on. In Manchester and Salford area, they found that those practitioners that have had carbon literacy training are really on board and passionate with this agenda, as opposed to those who haven't. So maybe a bit of wider education and specific education on this particular area. Then in terms of partnering, you know, like, can we partner with Asthma UK and Right Breathe charities to look at how they can support this education in what they do? Maybe it needs to go into the personalised asthma action plan that's already in there. You know, can we be putting things actually in that plan that help people know what to do with disposal, what to do if they're using more than 2 inhalers a year? Thought about e-learning modules and using the existing CCG shutdown events, we call them PLI events in Sheffield. And And then also empowering patients, maybe just using the patient label, the pharmacy label, so that it tells you what to do with your inhaler, and it sort of says, are you using more than 2 of these a year, say for your salbutamol, to try and get people to be, you know, to understand what to do. And then things about preset text, the accurate system, how can we use that system so that every time we're prescribing somebody something different, it gives them a little bit of information. It maybe links into a video or something that helps them with that. What else? We did talk a little bit about maybe needing to partner with patient advocacy groups. But I think that's it. Yeah, I think that's what we decided in our group. So Breakout Room 3. Is anyone from Breakout Room 3 who wants to feedback?
I can go. Right, I'll just get my Jamboard up. Yeah, so lots of discussions. We like the idea of sort of nudging clinicians towards using a dry powder inhaler, and this is something that we've done in Leeds, and we have seen a significant drop off in number of salbutamol inhalers used. And Toby Capstick, who is our consultant pharmacist, believes it's due to the fact that when GPs look at the guidance, dry powder is first, and Carol in Gloucester is doing a similar thing whereby they flip the MDI and DPI on their guidelines, not made anything blacklisted, because it is all about choice. And in Gloucester also there's sort of traffic lighting based on carbon footprint with regards to the inhalers, and also cost. So it's giving you a really a good, yeah, it's giving the choice when they're making those decisions on inhalers. We also talked about marked being a useful way of getting patients off the idea of SABA over-reliance, but we also recognise that it's not for everybody, and it's not about doing a blanket switch at any point. Sort of moving, you know, leading on from the discussion that we'd had earlier about making sure we get the diagnostics, you get the right diagnosis from the outset. We talked about PCM-based diagnostic hubs, and you know, and making sure that the right people get the right test done by the right clinician, and getting patients on the right journey from the outset. Interventions that are sustainable. So one of the things that we've done locally, and it's something that we were talking about in the chat earlier on, was instead of issuing a salbutamol inhaler and putting it on repeat for every 28 days, what we've done in my practice is make it 180 days. The trigger for a medication review is not the 6 monthly review, but it's actually based on whether they've tried to order more than 2 inhalers in that 6-month period. We've also put it as a you know, irregularly issued medication, and when the patient phones up, it triggers yeah, so they can't order it, so they phone reception annoyed. All the receptionists have been trained to talk to the patients to say, actually, we're not being obstructive, it just might mean that your asthma's not as well as controlled as it could be, and we'll put you with the on-call GP to have a chat. And with, you know, patients have been very receptive to this, and we have seen a drop off with salbutamol. It was initially quite a hard message to get across to clinicians who are quite used to putting everything on 28-day repeat, but now they know to start new patients with that 180-day if they're putting salbutamol on repeat. And it's similar vein to with GTN sprays and angina. So I suspect it's very rare in practices to routinely issue a GTN spray every 28 days. It's about getting that mindset about, you know, making sure that this is not something they should be getting every month. And also, again, Carol in Gloucester, they've had a universal comms message going out that actually we prescribe the Salamol rather than Ventolin, and prioritizing low propellant volume MDIs. And again, I think that's something that could be really you know, easily initiated across England. I think it's important with regards to resources that we get really simple guide. So I mean, we talked about here, so, you know, really simple guides for MARC, but actually simplifying guidance across the CCG, because a lot of patients, you know, they say they've got that sort of default, you know, Clenol, and that's about anything, you know, that's all they can think of. But actually, let's make the guidance simple, attractive, and easy to use, and it's much more likely to get buy-in and have wraparound education with that as well. So who can we
Sorry, Catherine, can I just ask you, sorry to interrupt you, you know, when you
yes.
said simple guides, attractive and easy to use, are you talking about guides for patients or guides for clinicians?
Guides for clinicians.
Yeah, okay.
Because I think certainly we're doing our guidance at the moment, and it, you know, it can feel really overwhelming. And actually, what we just want sort of, you know, and if you have got it on an IT system, so we have a separate, it's called Assist in Bradford, which is a portal just for Bradford clinicians. So, you know, for example, our long COVID template can be really overwhelming when you look at it, but actually it's just nice simple tiles, and you just click on the tile, and then it has the more detail behind it, but just make it simple. Oh, I've lost my
Sorry, I made you lose your word.
No, that's fine. Just a couple more things. I think you know, people that we can engage with, obviously industry, brightbreathe.com as well. So, you know, that's a very used resource, and about maybe having you know, things on there, alerting patients about the carbon footprint, but also working with IT systems as well. So System 1 and EMIS. I think it's important that it's not about alert, because I think, you know, I've got some alerts switched on at the moment. It's like, who has put this on? Catherine, can you switch it off, please? Because it's alert fatigue. It's not just about respiratory, is it? There's lots of other alerts going on. But for example, the switch that I did from the 28 days to 180 days, I had to do it manually. So I did 400 patients. It took a while, but it would be nice if you could just do that like a switch, you know, automatically. So I think working with IT systems as well. I'm sure I've forgotten stuff, so please chip in, anybody, things that I've forgotten to say.
Anyone else want to chip in from group 3?
Excellent summary, I thought. Thank you, Catherine. I think you're doing some exciting work at Leeds.
Really exciting. Yeah. Okay, so group 4 then. We've got plenty of time. We're doing well. We've got 10 minutes at least for group 4 to give us their thoughts.
I'll make a start for group 4. I'm not going to take 10 minutes. I'll start by disagreeing on the alert thing. If you're getting alert fatigue, then whoever's managing your alert thing isn't doing it properly, because we manage Optimize RX very closely. So if only when it does pop up, it's because it's important. So out of the 3,000 things you could be told about, we've got about 500, 600 turned on, and they are the important ones. We don't focus on cost, we focus on risk management and quality improvement. So there is something about getting those messages, getting the right messages on, and we will use those in terms of, we know we've got the long tail of people that we will need to switch away from carbon unfriendly things to the right thing. But actually, let's start with your initial prescribing, so we're not creating more people that we need to switch later, because getting it right first time is a lot easier than unpicking it later. So we'll use Optimize RX to try and get the right stuff, and down to two or three choices initially. So that's one of our big things, is actually getting it right first time through alerts, through Optimize RX. And again, we disagree on we have disagreement on things like switches, because we had somebody in the group, and I think he's had to go, who did proactive contact with patients through AccuRx, and they've had a 40% uptake. So people who are interested will change. People who are sort of interested will be primed for next time you see them, and then more amenable to change. And then the actual workload becomes in the people that it didn't float their boat in the first place, isn't that at your next annual review? They're probably the hard patients. but it's okay to work on the sort of the 80-20. We're never going to get absolutely everybody changed exactly the way we want it, but there will be the easy ones and the relatively easy ones. So let's not fear failure of 100%. Let's do what we can, change who we can now, and you know, rather than expecting it all to be absolutely perfect. We had a couple of different screens on Jamboard. I think what we were thinking was the stuff we put into the high impact ones, they need to be designed in a way that they are sustainable, not just high impact. It needs to be both these things, because if it becomes hard work and difficult, that initial enthusiasm that people have at the moment, and a lot of people do have that enthusiasm, will wane pretty quickly. So it's got to be doing the right thing, it's got to be easy, and it's got to be something we can keep going for some time. And I'll let the rest of Group 4 chip in if they want to add anything to that.
Can I ask a question? Sorry, Peter, and I will obviously not wanting to stop other people from Group 4 chipping in, but can I just ask about, so you said switching, being proactive and switching people now. Are you sort of saying that rather than just do this at the annual review, that we should be proactively sending out messages to people about potentially changing their inhalers as a sort of a bulk text message service or something like that, to see who's interested and then get them on board?
Yeah, so people who will go for it, so I think his name was Paul, I don't think he's here now, he said that there will be a bulk of a number of patients, about 40% he said, who are aware of the issue, who are almost waiting for permission to do this sort of thing, so responded really, really positively to this. And then you've got other cohorts that are less switched on, less clued up, less amenable. So there's probably a spectrum of people, but there will be people there who will respond positively to just, we want to switch you to this.
This was a piece done by his registrar, who I think was also on this webinar, and I think also has now gone, but he said that it was done as an audit. So she contacted, I think, 103 patients with a message, asked them to switch. 38 said immediately that they were happy to switch. And I don't think they even had a consultation. I think they then just switched them and sent them information via QRX and invited them if they had further questions, with links to video to show them how to use their new inhaler, and an invitation to speak to the practice-based pharmacist if they needed to. And then he said even others then were sort of caught ad hoc in consultation, you know, and a lot of them he didn't have a figure, but he said a lot of them will have then said, oh yeah, I thought about that message, I haven't had a chance to get back to you, but I'm happy to switch. And he said, which I thought was really nice and something maybe that hadn't occurred to me before, that unlike other switches that have happened historically for other conditions, like lots of people buy into this, like lots of people, you know, this is an issue for lots of people that lots of people hold close to their heart. And I think normally, you know, there's a suspicion from patients that this is all about money, and clearly in this instance it's not. And so people, he said it's the easiest script switch they've ever done.
No, that's really interesting, because I was wondering, that was going to be my other question, was did it generate consultation work to do that? You know, did that mean that a nurse had to see them or a pharmacist had to speak to them, or, you know, but didn't seem to. Okay. Sorry, did somebody else from Group 4 also want to talk? Sarah, did you want to say something?
I think the only other thing I was going to add, and it may have come up already, was about just making sure everything's aligned with secondary care, so that, you know, things that people are getting sent discharged from clinics on or hospital matches what we're trying to do. But I think everything else has been said already.
So maybe just opening it up to everyone now. So we've had lots and lots and lots of ideas, which is great, in lots of different areas. I think we have had some things that have come back again and again, you know, about making it sustainable, making, trying to see if we can get IT to work with this, and potentially looking at support from community pharmacy. And there's an element of education as well. I mean, I'll have to look through all of the work here, everything that's been said, to see where the key places are that we've decided as a group that we want to go forward. But does anybody want to say anything else? Has anything been sparked off for you by what's been fed back that you just want to talk about or mention?
I forgot to mention, actually, and this is a project that we're doing across West Yorkshire and Harrogate STP. So it's with it's a behavioural change model called Tiny Habits, and we're getting training for. We've got funding for 5 clinicians across the STP to identify patients with high SABA use and to train them in this behavioural change model. And it's very simple. It's just it's an ABC. You teach the patients to. It's about improving ICS inhaled corticosteroid adherence, with the view being get good asthma care right, and then the SABA will just naturally drop off because they're taking their steroids. So they get identify an anchor, so something that they're doing on a regular basis, something that's automatic, cleaning the teeth, turning on the kettle, and then they attach their new behavior, which is taking their inhaled corticosteroid, to that, and then you get them to choose a celebration, so something that that feels authentic to them, whether it be high-five in the mirror or just feeling good inside. So we're doing a pilot study. I think we're aiming to do 50 patients per clinician that's been trained up in the Tiny Habits model, to see whether we can reduce their SABA overuse, and that's all part of the carbon footprint project that we've got going in West Yorkshire and Harrogate. So
brilliant.
How it goes.
Thank you, Catherine. All right, Rami, I'm going to hand over to you to sort of close the session and talk about what we're going to do next, as what we're going to do in terms of maybe forming a working group and taking this work forward. I can't actually see you on my screen.
Oh, can you see me now?
Yes.
Yes, okay. Yeah, thanks, Artie, for that. I've been trying to follow the comments in the chat as well. It's clear that there is so much expertise within this group, and that there are so many ideas. And I know that there's already a lot of work that's gone on in this area, but it also feels like there's a real momentum now around this. And I think it's about making the most of that. And I'm hoping that today is a springboard for a bigger piece of work that we can do over the next few months, that will put us all in a good position to be able to influence and suggest changes, and make use of any incentive schemes and things that are on the horizon. And in order to do this, what we'd like to do is set up a small working group, consisting of a few people who are willing to put some time and energy into perhaps creating resources or reaching out to other organisations that we may want to partner with and influence. And the first step to all of this is going to be actually writing a short proposal. We've had sort of a signal from the Health Foundation that they'd be willing to put some money towards this, because this is an area that they also feel quite strongly about. So our first sort of job after this would be to put together this proposal of what it is that we want to do. And obviously that will involve reflecting on what's been discussed within this meeting and what's on all the jam boards. So if you are interested to be one of those people and feel you've got some time to give to this, then I would urge you to please get in touch with me. So I've put my email address within the chat, just to let me know that you are interested. I'm aware and conscious that not everyone is going to have the time, because I know everyone's got busy lives and they're involved in multiple other things as well. But even if you don't, then what we would like is obviously for people to still give their review, like you'd be open to review the work that we're doing or to give comment and so on. So I guess what we're looking at is forming a small working group with a few core people, and then a wider group who are going to be sort of friendly critiques in a sense. So yes, I'd like to just finish by urging you all to kind of stay connected and get in touch and express an interest if you are keen to be part of that working group. obviously, we'd like to get representation from kind of a wide group of disciplines as well, just to make sure that sort of primary care is being adequately represented and that we're able to influence at multiple levels as well. So yeah, look forward to hearing from you all, and thank you all for your time and enthusiasm during the session. Thank you.
Yeah, thank you everyone for coming, and it's really, really great to just see everyone as well. Looking forward to hearing who's interested in taking this work forwards. But yeah, thank you very much, and hopefully speak to many of you again soon.
I'll post about the working group in the Q primary care group as well. If you haven't, I'm hoping that you can all see my email address. I'll post it again once more, just in case though. Great, thanks everyone.